we have Dr. Nader Sanai, and he's going to be talking to us about phase 0 clinical trials, current recruiting clinical trials where he practices. I would like to read a little bit about Dr. Sanai if I could. And I'm also extremely excited and honored to announce that Dr. Sanai has joined our medical advisory group. So I'm really thrilled. Thank you so much, Dr. Sanai. We all look forward to working with you closer, all of us from the In-Brain Cancer Initiative. So Dr. Sanai's bio is this. Nader Sanai, MD, is the J.N. Harbor Professor of Neurological Surgery at the Barrow Neurological Institute, which is in Phoenix, Arizona. His specialty in neurosurgical practice is devoted to patients with benign and malignant brain tumors, particularly those in high-risk areas. He is a renowned expert in brain mapping techniques to identify and preserve areas of motor, sensory, and language function during surgery. As one of the nation's highest volume neurosurgical oncologists, Dr. Sanai was elected to the American Academy of Neurological Surgeons in 2016. In 2018, he founded and now directs the Ivy Brain Tumor Center, a not-for-profit drug development program specializing in phase 0 trials and driven studies for brain tumors. So Dr. Sanai has authored more than 200 peer-reviewed publications and delivered over 100 national and international lectures in neuro-oncology. Ladies and gentlemen, I would like to introduce you to Dr. Nader Sanai now. Oh, there he is.
Thank you, Dylan.
Hi.
Hello, can you hear me okay?
Yes.
Okay, well, I'm honored to be part of this. I was just listening in. It's so inspiring to hear these stories and to see and meet, our community of patients and caregivers and providers as we're coming together to beat this disease. So, Dylan, you asked me to talk a little bit about some of our early phase trialing efforts, which I'm going to do. But I just want to reiterate, I think, some of the themes that I've heard so far, because it's so important for patients and caregivers to hear this, which is that the challenge with this disease in many ways is that it's different for every patient. And so what that means is what perhaps didn't work for some patient you met may work for you, and vice versa. And that's why, to echo the sentiment said, it's so important to cast a wide net when you're looking at your options. It's so important not to give up hope.
Yes.
Because even if something didn't turn out well for the patient before you, it doesn't mean that's the case for you. It's a really individualized disease to struggle with, but that means there's an opportunity here for each of you to have a future very different from what you might see or read about on the internet that sounds so scary. As Dylan mentioned, I'm a neurosurgeon and a brain tumor researcher. I'm at the Barrow Neurological Institute in Phoenix, Arizona, and we have a brain tumor research program here, probably one of the largest in the world, that focuses on drug development, called the Ivy Brain Tumor Center. These are my disclosures. I don't take any money from industry. I have no paid relationships with any specific therapies. This is part of our policy here at our program, which means that I'm agnostic to what may or may not work. I'm just looking for the data to support anything promising. I think everyone here is familiar with the tumor and how quickly it can recur. You can have an operation on one weekend, and then as you're waiting to get other treatments or getting them, the little cells of this tumor are spreading. And this is the exact problem. In our field, we often have a refrain that we say, gliomas are not a local disease. And what we mean by that is that this is not a tumor where an operation can cure it, as many of you know, because there are components of the tumor that you can't see. This is why even for patients that get aggressive therapy, like this patient of mine, the tumors can grow back, often do. And this is why the treatments have to be global. As all of you know, there are 4 general treatments that are proven to be effective. Surgery, the chemotherapy temozolomide, fractionated radiotherapy over 6 weeks, and Optune, which I think you're going to hear about. Outside of those 4, everything is experimental. It doesn't mean it can't work. It just means it's not proven to work. And there's a reason why we only have 4 things. The first is, this is a really complicated disease, way more complicated genetically than any other cancer. So this is what's called a karyotype. These are all the chromosomes, which are the little structures in your cells that contain your genetic material for a normal cell in a normal patient, in a patient without any disease. This is how it's supposed to look like. It's nice and neat, it's symmetrical, it's very predictable. There are 23 chromosomes that encode everything in your body. This is what the karyotype looks like of a glioblastoma. So, first problem, you don't need to be a scientist to see that the thing on the right looks nothing like the thing on the left. This is a big problem for us. Unraveling this disease means we need to understand this. Second problem, as many of you know, developing therapies for brain cancer is not a priority for the biotech and pharmaceutical industries, which is very understandable. These are for-profit industries that base their investments on the size of the market, and the brain cancer market is not very big. So it's actually very simple to predict where you're going to get new drugs, because it's directly proportional to the size of the market that the drugs will go to. And so it's not a surprise when we look at the last 5 or 6 years of cancer survival trends that brain cancer and other brain tumor type cancers really have had no significant change in their survivability, but something like melanoma or lung cancer, which are extremely large markets, have had really substantial survivability changes. So this is another factor that causes us to swim upstream. The third factor is that similarly, the federal government and the national efforts at brain cancer are comparatively small to other national efforts for other cancers. 25 years ago, we started to create these large consortia of centers, which are sort of groups of major universities and brain cancer centers working together to develop new drugs. And little by little, the amount of funding for each of these efforts went down, and the number of groups went down. And 10 years ago, there was only one group called the ABTC, and today there's no groups, with the ABTC losing its funding. Now, this doesn't necessarily mean we can't make progress, but it just speaks to the fact that, generally speaking, in our country and worldwide, it's all about political will. If you think about HIV/AIDS in the 1980s, it was completely unsurvivable and it was a death sentence. But there was enough political awareness and political will where resources shifted, priorities shifted, and today it is a very survivable disease because we developed 3 or 4 new classes of drugs that treat it very effectively. Now, the companies themselves that are in this space also have their own priorities. And so sometimes their priorities and maybe what's better for the greater good don't align. And the reason for that is because there's only a limited number of brain tumor patients. And so when we have clinical trials, there's a limited number of people that can enter those trials. The fewer there are, the harder it is to get an answer to a clinical trial. So when companies kind of follow bandwagon trends and open up a lot of trials, many centers have no choice but to open these trials as well, because that's where the funding is coming from. But in fact, some of those trials shouldn't be open. And some of those trials really are unpromising, but nevertheless will happen. You see that today with immunotherapy. Today in the United States, there are more slots for immunotherapy trial patients than there are patients available. So it gives you a sense of this extreme sort of bandwagon mentality that makes it difficult to have diversity of trials. And another thing that really works against us is unfortunately, is just the extreme commitment of the scientists and physicians in this community. As you've seen today, and as you've probably learned in your experience, these are very dedicated individuals. And sometimes that dedication just takes you too far, where it's difficult to look at a trial and say, you know what, this is not working, or it's not working well enough. We should move on. We should stop trying to fine tune this and really just reallocate our resources towards a totally different effort. But it's difficult for investigators and doctors and scientists to make that choice sometimes, because they want it to work so badly. So this was an editorial by Lisa DeAngelis, who's the head of, or what at the time was the head of neuro-oncology at Sloan Kettering, and now she's the physician in chief, making this exact point, which is that, you know, sometimes if a trial is not promising, that's what it is. It's not promising. It's not going to get better. We need to move on. So the Ivy Center, which is where I'm at, tries to take all of this stuff in mind when we develop clinical trials. So first of all, one of the distinctions that we make with ourselves is that we pay for all of our own clinical trials, which means that we don't take any industry funding, which means that we can make choices irrespective of where the funding is. Number two is we focus on drugs that are new to glioblastoma patients, meaning if there's a clinical trial at our center, we make sure that this is the first time glioblastoma patients are seeing this drug. If other centers are doing it, well, then that's good. They should do it, and we should focus on somewhere else to try to cover the most ground. And finally, all of our trials are what are called tissue-based trials, because one of the big challenges with clinical trials is it's hard to know if a drug is really working. As some of you know, the general way a clinical trial works is you're past those 4 standard options. You go to your doctor, they say, you know, I don't have any more proven options for you, but I'm going to make an educated guess that maybe this experimental therapy works for you. So we're going to take that educated guess on faith. You're going to take this experimental drug for a couple months, then we'll get a new MRI, and hopefully in a couple months, it looks better. And obviously the problem with that gamble is that a couple months is valuable time, and there's no guarantee it will work. And in fact, in many cases, there are problems with getting new drugs into the brain, for example, or having the effects that you want to have. So the way we do clinical trials is a little bit different, and you may have heard this term phase 0 clinical trial, but it basically begins with a genetic screen of the tumor, and then the patient is sort of, again, matched to the best educated guess we can make connecting the genetics to a new drug in our portfolio. That might be a single drug, it might be what's called a drug cocktail, which is a combination of drugs. It might be a drug and a device. But the point is that instead of just asking the patient to take the drug and then hoping for the best, we give it to the patient before surgery. And that way, when the operation happens, we can take the tumor out. This is only a few days after getting the drug, so there's no real side effects after a few days of any drug. We can test the tumor and say, did this drug get there? Did this drug hit its target? Is this drug having a detrimental effect on this patient's tumor? So this is very individualized. It doesn't matter what happened to the patient before or the patient after. It's about this specific patient's response to this specific new drug therapy. And so we get the answers to those questions in about a week, which means that by the time the patient is recovering from surgery and out of the hospital and all of that, we know, is this drug going to have a chance of working or not? If the answer is no, well, then the patient never goes on the drug. And we're back to where we started at the beginning, which is we need to find something else. But if the answer is yes, well, then now we can all have some confidence that it's worth this patient going through whatever they need to go through to take this drug for a couple months. Everybody has more confidence and everybody has more hope. And the way these clinical trials are designed, they're not really designed to detect some incremental benefit of a drug or a therapy. Because I think we can all be honest, that's not what we're looking for. We're not looking for a 10% improvement in survivability, a 5% improvement in survival. We're looking for home runs here. So we want to look for things that are clearly working. If it's not clearly working, we just move on in our program. Other people can try to fine tune whether that's going to work or not, but we don't think that that's a priority for the patients. The other thing that's really a priority for patients is managing side effects, because we all know that all of these treatments have their consequences. And so the classic way that clinical trials are done at most centers is you get a new drug and you just keep giving the drug at higher and higher doses until the patient gets sick. And when they get too sick, that's kind of the ceiling. And that's kind of the highest dose of the drug that patients get. So that's how clinical trials figure out how much drug to give a patient. They basically give patients one level below the highest possible level a patient could tolerate without getting so sick they can't take the drug anymore, which is really an old style of thinking, because in the 80s and 90s, most drugs were true chemotherapies. A true chemotherapy is just a toxin. Most chemotherapies are derivatives of things like mustard gas. So it's just designed to poison everything and hopefully poison the tumor more than it poisons your body. So when you have a drug like that, which is not a great drug to be on, it's true that the more drug you give, the more effect you have. But today's drugs are not true chemotherapies. Most drugs today are targeted inhibitors and other precision type drugs. And those drugs don't work by just giving more drug and having more effect. Those drugs have a sweet spot. And that sweet spot is often not the highest dose of the drug. In fact, for many drugs that are experimental, if you just maximize the dose based on what the patient can tolerate, that actually has the minimal effect on the patient. So in our trials, what we do is we don't look at the toxicity of the drug. We don't want to even see drug toxicity. We look at the drug effects, and we dose the drugs based on the drug effects because we have that evidence in front of us. We're not looking at a scan and trying to interpret what we're seeing and read the tea leaves. We have the patient's tumor, it's been exposed to the drug, we know exactly what the drug did and did not do, and so we can be very specific. And this lets us give patients lower doses of drugs with more effect. So I'll just walk you through three kind of different paradigms. We have many trials at our program, and obviously there are many trials worldwide, but three concepts of how this kind of strategy is working. One is the concept of moving away from single drug therapy, because everyone in our field feels pretty confident that a single drug is never going to be sufficient for this kind of tumor. So what our group or our center has done, and others have tried to do this as well, is we start off with single drug trials like we did several years ago, and we use those drug trials to figure out what is the resistance mechanism to this single drug. And then we move on to new trials like this one that's combining two completely novel drugs together to undermine that resistance mechanism. So a trial like this, it involves a drug called abemaciclib, which is a cell cycle inhibitor, and then it involves this drug with this acronym, which is typical of new drugs that are so new they don't even have a name. And this is a new drug from Eli Lilly. And so patients get these two drugs before surgery for about 6 days. And then on day 6, they go to the operating room and they have their tumor removed. And then we ask a simple question, which is, did both of these drugs get to the tumor? And did both of these drugs do something positive to the tumor? And if the answer to both is yes, then the patient goes on to both drugs. And this is the kind of data that we get from this kind of trial. Every column here is a different patient, and these are the concentrations of the two drugs in each patient. And the patients in red had enough drug get into their tumor where we know it can be effective, and the patients in white did not. So we only want to give experimental drugs to patients where we think those drugs have real smoking gun evidence that it's going to work. If not, this isn't about, playing roulette here. Okay, we want to play chess, and that means knowing the data and not just hoping for the best. So this is the type of data we get from these patients, showing that the biomarkers that we want to change are changing. And so these patients have a much higher chance of responding to the drug than the average patient. The second kind of category of trials that emerges from this is combining a drug and some other modality. So drug plus radiotherapy, for example. Radiation therapy, as much as we all don't want to have it, is actually the most effective single therapy for brain cancer today. More effective by itself than surgery, more effective by itself than Temodar or Optune, and it's very accessible to patients worldwide. So improving how effective radiotherapy is a very viable strategy. And tumor cells have lots of different ways to get around radiation damage. And so what we do is we target these little resistance mechanisms they have and combine it with radiation. And this is another important point, which is clinical trials are not just for when the tumor recurs. Clinical trials can be done at the time of initial diagnosis. And in fact, half of our patients with newly diagnosed tumors are on a clinical trial that combines experimental therapy with those 4 things that we know are proven to be effective. Why is that? Because as the tumor progresses longer and longer, it becomes more and more convoluted, and it's harder and harder to control. The best option, the best opportunity we have to control a tumor is when we first see it, when it's pure, unadulterated, relatively simple compared to what it's going to become. So this is a new in class drug called pamiparib, which is what's called a radiosensitizer. And this is a whole new generation of drugs that we're now deploying for the first time in glioma patients. And we can look and see the genetics of the tumors as they respond to these drugs. And this is why it's so important to take this one patient at a time, because different patients have different tumor genetics, even though they're all called glioblastoma. If you look at every row here, every row on the right is a different patient. None of them are the same. Everybody has their own version of a glioblastoma. You have to have individualized solutions. The final category is something called metabolic targeting. And in broad strokes, this is based on the concept that brain cancer cells still require metabolism. They still require the ability to generate energy for themselves like normal cells. So you can exploit that. And so this is what's called a new in class or first in class, first in human clinical trial, meaning this is the first time any human has had this therapy called sonodynamic therapy. And this is a combination of a drug and a device. And so what happens is the patient comes in and gets a drug, and that drug has no effect by itself on the patient's tumor. It's not toxic, it has no side effects. Any one of us could take this drug and we would feel fine. But the drug is like an amino acid, and it gets metabolized by the tumor cells. And because tumor cells are abnormal, they metabolize it abnormally, and they create a byproduct that they don't normally create. And that byproduct, coincidentally, can be activated by ultrasound energy. So the patient gets targeted ultrasound to the tumor. The ultrasound energy by itself, again, has no detrimental effects, but then the convergence of the two become lethal for the tumor cells and only the tumor cells. So here's a little video of the first patient worldwide that had this therapy not too long ago.
Today is our first patient for sonodynamic therapy clinical trial. This is the first in human study. So sonodynamic therapy is a combination of a drug and a device. It's non-invasive, doesn't require an operation. A patient with a malignant brain tumor gets this drug the morning of the procedure, and then there is a frame placed on the patient's head. It's fixed to the patient's skull. It's done with local anesthetic, so it's painless. The patient doesn't feel any discomfort. And then following that, the patient goes into the MRI scanner and gets attached to the sonodynamic therapy device.
So these types of trials are important as well, because obviously, number one, we want to be trying new things. We don't want to be recycling things that have been around for decades. And number two, because these are entirely new dimensions of treatment. This is not surgery, it's not radiation, it's not chemotherapy, it's not Optune. It's a whole nother category. We call it a new modality. So it's something you can layer on to everything else, and that's why it's important. This is how the targeting looks when you're targeting the tumor itself. And this also is a phase 0 trial, which means that we remove the entirety of the tumor, like you see here, and then we look and say, did this patient benefit from this sonodynamic therapy or not? And we can say that definitively. There's no sort of hand-wringing, trying to interpret a scan. We see the evidence or we don't in the tissue itself. And if the answer is yes, then they can go on to get more treatment if and when the tumor recurs. So again, it combines a drug that's given, followed by targeted ultrasound, and then the patient goes to the operating room and we measure all of these things related to that. So I know I didn't have a lot of time. I'm sorry if I went a little bit over. The Ivy Brain Tumor Center is a huge family of people that are all working on your exact problem. These are the faces of people that only spend 24/7 thinking and trying to unlock glioblastoma. We are completely focused on this singular mission and completely focused on getting patients and family members new therapies, because that's what really is going to move the needle, as you know. So with that, I will wrap this up and thank you for your time and attention.
Thank you, Dr. Sanai. That was truly amazing. And this patient population learned so much from you just now. Thank you for taking the time to explain. I also want to thank you in advance, actually, for your slides. Your slides were really easy to understand. So thank you very much. Really appreciate that. I want you to know that you have more time. We've adjusted our presentation schedule and you have more time. So please feel free. I don't want you to feel rushed, which also means I don't want any questions that you all might have. I don't want you to feel rushed. I want you to make sure you ask your questions. I have probably 2 in my chat box, so I'm going to access those and I'll ask you, Dr. Sanai, all right?
Sure, I'm ready.
Okay, it says, oh, good question. Mary Kay asked, Dr. Sanai, oh, where did it go? Does this information apply also to grade 2 astrocytoma? Very good question.
Right, so that's a great question. There are different grades of gliomas or astrocytomas. We grade them 1 through 4, as everyone knows. Grade 1 gliomas are typically curable with surgery. Grades 2, 3, and 4 typically require more than just a single round of treatment. Each of these grades have their own biologies. So the short answer is yes. There are clinical trials like the ones I described for grade 2 patients, grade 3, grade 4, and all of the subtypes within it. And that's why it's so important to make sure that as much is understood about your tumor as possible, especially the tumor genetics, because most clinical trials today rely on seeing those tumor genetics to match you to the right therapy.
I have a question, if it's okay to ask. There was a fairly recent change in the NCCN guidelines related to astrocytomas, right? Are you able
Yes.
to explain that a little better for all of us? All of us.
Sure. So astrocytomas in general, and we just call them gliomas, and there are different words for it, but it's all the same. Have been kind of recategorized in recent years based on their genetics, and there are a couple new developments in that space. The first is that some patients where we previously thought they had a grade 2 glioma have the genetics of a grade 4. So this is called a molecular GBM, meaning on the imaging, it looks like a grade 2, but genetically, it's actually a grade 4. And so those patients need to be treated accordingly. They can't be treated like a grade 2. And the other dimension is our management paradigm for grade 2s. If you're under 40 years of age and you have a grade 2 glioma and you have surgery and there's no sign of the tumor on the MRI after surgery, then the current management recommendation is not to do anything else, just to watch it with MRIs every 6 months. But if you are over 40 years of age with a grade 2 and the tumor has been completely resected, the recommendation is to treat it like a grade 4, meaning to do both temozolomide plus radiotherapy. Similarly, if you're under 40 with the grade 2, but the tumor was incompletely resected, meaning you can see some of it on the MRI afterwards, then either you need a reoperation to get the rest of it out, or if that's not possible, you should go on to get the same treatment as glioblastoma patients do, which is temozolomide plus radiotherapy. So in general, what we're recognizing is that even the tumors that we think are a little bit safer to have sometimes are not. And generally speaking, if there's an opportunity to be more aggressive, it seems to make sense for us to do that rather than to watch and wait.
Thank you. Very important. Very important. A question came in, another question that I would like to read to you, if I may. Thank you, Dr. Sanai. Do you do virtual out-of-state second opinions?
Yeah, of course. So about a third of our patients are out of state, out of country. We do second opinions, in state or out. An important thing for you to know is that when the pandemic happened, the federal government loosened the restrictions on out-of-state virtual visits. They basically said anyone can do it in any state and it's all billable through insurance. But now that the pandemic is starting to subside, the rules have gone back to how they were before, which is basically that you can't do out-of-state consultations in a billable way. So you can still talk to people, but it can't be an official clinic visit anymore. Our response to that has simply been, we don't bill. We'll do virtual consultations. We'll call them courtesy consults, so it doesn't get misconstrued as a billable clinical visit. And we just do it for free to just help patients sort through their options. I just spoke to a patient yesterday in New York. They had just had a surgery, at Cornell. They're doing well. I don't have anything to recommend to them that their local team can't do, but I think sometimes it can be useful just to hear it from a different source, so you make sure that you're covering all your bases. So yeah, we do that routinely.
Thank you. Another question came in. You talked about this a little bit, but maybe you can expand on it just a little bit. It says, thank you for sharing. My partner is 1.5 years out from original diagnosis. When would be a good time to get in touch with you guys, now or after a recurrence?
Right, that's a great point. So I know that it's anxiety provoking to be constantly in treatment mode. There are windows, and for some patients, long windows where nothing's happening clinically, and that's good. And we want patients to get back to their lives. You can't constantly be in vigilante mode. You want to live your life. But that being said, it's never too soon to start establishing relationships with second opinions and other kind of, experts in the field. Because if you ever do get to the point where something has changed on the scan, you want people involved that already know your case and already are following along. So at the Ivy Center, we basically have this surveillance mode where patients that have had standard of care and are currently don't need anything and they're doing fine at other centers, other sites, other countries will connect with us. And we'll just make sure that whenever they get a scan, that we get a copy. And that way, anytime they get a scan, they hear from us as well. They also hear from their local team, but it's always like an additional check. And then if and when there's something new and we need to talk about a retreatment, it's a lot easier for us to give, informative sort of advice.
Thank you. I also want to remind everyone that we will be providing the information necessary to reach out to all of our presenters today after this event. So just so you know, you'll be able to reach out to Dr. Sanai and his team if you have more questions and you're interested in that second or third or fourth opinion or any of the treatment options he spoke about today. Another question came in, and this is a really good question. We hear this a lot. It asks, what is the best way to find out the genetics of my tumor?
So most centers that treat brain tumor patients either can do the genetic screening themselves. And so in that case, you just simply speak to your neuro-oncologist and say, can you please genetically screen my tumor? And for centers that don't have that capability, there are several national programs, national companies, Foundation Medicine, Caris Life Sciences, and there's a handful of others, and they're all pretty much the same. In my experience, one of them doesn't really provide any significantly better information than the other. Those things are billable to your insurance as long as the tissue is sent more than 2 weeks after your operation. So anyone can get it. Insurance companies cover it. And it's a great set of data to have. Now, the important thing to remember is most of the time when you get these genetic screens, it's not going to tell you, oh, you should do this or you should do that. The genetics are not that informative, but they can be helpful in guiding you to experimental therapies later or guiding your doctors. And that's why it's good to have it in hand.
Thank you. I have to ask you the last question, although we literally could spend hours because you're so informative and the patients and caregivers who are watching this are so engaged. They have a lot of questions, which is wonderful. Last question. Do you also perform these trials on patients with pacemaker dependent and abandoned pacemaker leads? I've been told that having an MRI is possible, but need to find a treatment center that will perform this.
Right. So obviously, sometimes patients have other medical issues outside of their tumor, and cardiac issues are not uncommon. And for some cardiac patients, they have pacemakers. And some of those pacemakers are MRI compatible. Some of them are not. Some of them can go in the MRI if you switch them off. So number one, it's important to know what category you're in. And the easiest way to figure that out is either to ask the office of the cardiologist that orchestrated the pacemaker, or to simply call the company itself, because the companies keep track of every pacemaker in every patient. Now, if you have a pacemaker that's not MRI compatible and you have a brain tumor, you need to first ask your cardiologist, do I absolutely need this pacemaker? Because sometimes after a period of time, you don't. And if the answer is no, then you should get it out, because MRIs are so helpful in tracking brain tumors and CT scans are much less helpful. However, if you're in the category where you need the pacemaker and you can only get CT scans, well, then everyone's got to do their best. And that's how we approach it at our program, and most centers do the same. You're not excluded from a clinical trial because you can't get an MRI. It's just that it's a lot harder for everyone to keep track of the tumor, but we'll still do our best.
Thank you. Okay, I promised that was the last question, but I am going to ask one more, and then we'll
No worries.
and then we'll move on. I do want to let everyone know that we have rescheduled further down in this program, Dr. Chautka, who will be speaking about gamma tile therapy and the new Rhodes clinical trial. So we'll be hearing from him a little bit later on in our program. The question that came in that I think is really important, and you did address this, maybe you could address this a little more. Do GBM patients need to be at an early stage of their GBM journey to qualify for these, quote, new, end quote, trials?
Yes. So every trial in general has its own set of criteria. I showed you some trials where it's just for newly diagnosed patients, and then I showed you other trials for recurrent patients. So depending on where you are in that journey, that will dictate what trials are options for you. But in my experience, almost always there is a trial option for any patient at any stage. We routinely have trial patients that have had 2, 3, 4 prior operations, and that's fine. You know, I think that if you've had that many operations, it actually means you're doing pretty well, because you've had these opportunities to get retreatment. So don't be discouraged if you feel like, you know, or you've been told, oh, well, your tumor won't qualify for any trials. That's usually not the case. But, you know, the answer is always individualized.
Thank you so much. I know everyone joining us today truly thanks you, Dr. Sanai, for your time, and your education today is invaluable. So I just want to say again, thank you. And I appreciate your time and your expertise. And I also want to thank you again for joining EBCI's Medical Advisory Board. This is amazing. We're so excited. Thank you. And again, we will be sharing the information on how to reach back out to you and your team that we're allowed to share with everyone who's registered today. Okay.
Thank you, Dylan. Thank you,
Awesome.
everybody. You know, keep pushing ahead. I'm here for you guys. You need anything, you have my contact. Our whole team is ready. And, you know, I wish you all the best, and we'll continue to push for the same fight.
Thank you. Thank you so much.